So it's an 84-year-old male, hypertension, hyperlipidemia. He's got multiple PCIs, last of a CTO RCA in July 2022, PAD, multiple PTAs, as you'll see, diabetes, osteoarthritis, chronic anemia, back pain, spinal stenosis, pacemaker, paroxysmal AFib, and his prior CVA. He presented actually last week with complaints of ongoing bilateral leg claudication that's really progressed to rest pain. No open wounds or ulcers in the lower extremities. He's Rutherford category 4. His duplex showed obstructive PAD of the right SFA and right pop with severe diffuse interpopliteals. ABIs on the right is 0.47. He's on metoprolol, hydrochlorothiazide, Eliquis, and Plavix, and the creatinine 0.7, hemoglobin of 8.9. This is his film. So as you can see, he's got a prior stent in the SFA, actually two, with moderate to severe disease in the SFA going down, and then really a flush occlusion down in the P1 segment of the popliteal.
Total nonsense.
Over here you see down below the knee, he really just has, you can see filling late on the right slide, he's got really just a perineal that goes really all the way down to the foot, as you'll see over here. So really just one vessel runoff. Big collaterals coming from up top. With that, we'll get started here.
All right, so thank you, Usman. All right, here's Dr. Karthik Guja, who just joined us
Sorry, everybody.
for the lab. All right.
The president is in town, so.
Yeah, traffic has been crazy. All right, so just to go over the live pictures we took right now, here you can see the axis on the left side. Patient has significant PAD, both by clinical symptoms and ABI. And you can see the left side axis, and already there is left significant ISR of the left SFA. The iliacs themselves are unremarkable, slight calcification, but overall you can see both the common and the external are nicely patent with no significant disease. Going on the right side, we have the DSA angiography shows the proximal has some disease right there, but the meat of the case starts from the middle of the SFA all the way down. So as you can see at the lower end of the screen, there is some ISR and significant lesion in the mid SFA, which is right up there. And further pictures down, you're going to see a completely occluded SFA just at the beginning of the adductor canal. So that's our SFA right there approaching the popliteal with some collaterals going down. The sad part is the reason the ABI is horrible is because the next pictures will explain it themselves. You can see the collaterals. There is this very small island right there in the pop, which is maybe like 2 millimeters if you want to call it. And then again, it's a CTO all the way down. And there is no real ATPT. All you can see is a distal reconstitution of the peroneal right in the center. So your main vessel supplying all the way down to the feet is essentially a peroneal. And here it comes. You can show significant collaterals coming from your distal segment, but that peroneal is your main vessel, which is through the lateral calcaneum, supplying your dorsalis pedis, which essentially reconstitutes right at the ankle. So the AT and the PT are essentially non-existent. So that's the reason this patient has clinically significant disease and now presenting with critical limb ischemia, resting pain, and with this angiographic presentation. Right, so here you can actually see, that's what we and Karthik have figured it out, is it's very essential to have a microcatheter to support in this case because the lesion is so long, we are up and over, so the torqueability and the pushability of the wire is a big limiting factor. So in this case, we really have to have as much maximum strength, or what would you call it, as support to get our devices, our wires down. And you can actually see what's prohibiting us, and especially the catheter going down, is that tight lesion in the ISR, in the stent itself, which is the ISR. So before we start putting all the stuff down, trying to cross the lesion, we want to make sure we dilate that proximal stent as well. So I think our approach here would be to just dilate the stent, maybe just a PTA to begin with, and then we can start working distally at the CTO segment as well.
5060 balloon.
So we're going to start with the 5060 balloon. We haven't, so I mean, again, the approach of intervention is a lot of operator dependent, but also a lot of experience that comes with it. If it's a pure SFA CTO, which I'm sure I'll ask Ray and Karthik as well, Usually the approach is being aggressive enough where I would personally use an 035 upfront to go in and fix it.
Yep.
But in this case, I think we take a step back in our strategy and try to be more quote unquote gentle to begin with. So that's why we are up to 014 approach itself. Right. So I think that's a very important point to consider, especially when you're trying to do interventions like this, is try to your chances of being intraluminal are on a much lower side. The probability is less than 50%, I would say. Even in the best of the hands, best of the operators, we know from previous experiences that even if it might be a CTO and even if they claim, especially a true chronic CTO, even if they claim that they were intraluminal all throughout, the chances are still low. You can go in and out of plane, you can go intraluminal, extraluminal, and then come back in. Right, so the Astaro group of wires, which we routinely use here, are great wires. So they come in 20, 30, and 40. That's the gram tip weight on the wires. Just for you to consider, 20 is an 014 system, but while a 30, 40 is an 018. So you obviously have to be cognizant that the microcatheter that's providing you the support it should fit in there. So if you take an 014 microcatheter and you want to exchange it for an Astaro, you won't be able to do it. So here you can actually see that the wire is making some progress, but there is a little bit of turn or loop around it, but the ease is much better
The roadmap.
because of the weight and everything. So, good. Hold on.
We were
So we're
just
gonna,
taking a roadmap to see the segment of the P1 segment, the island which it is, so which will give us a direction.
correct.
So we see we are a little bit off there, but I think we can still try and see if we can get into that segment.
Right. So I think that's a very important point is to really connect the dots. So in this case, Karthik is trying to do is trying to see if we can move his wire towards the segment. And here you can actually see it's moving towards it, but it might be spiraling around it. So sometimes what you got to do is we might have to take some other orthogonal views if we have to, just to really position and see where the wire is. So the Astaro is working good, but I think it's just
That's a branch.
yeah. So it's catching branches as well, which is sometimes a good sign, but at the same time we want to stay in line and work from there. Well, I mean, if the wire stops making personally, if the wire stops making progress, if you hit a roadblock, or if you're spiraling a lot, let's say I'm not able to connect that island, or even after that, and I'm way off it. If I'm very close to it, I'll probably pull back my wire, redirect it, like you would do, and then take it from there. Like in this case, I pull back a little bit and maybe redirect it more medially to see how it behaves. But if I'm unsuccessful, I think I like that spot. If I'm unsuccessful in it, then I would probably switch over to pedal slash peroneal, in this case, a peroneal axis at the earliest. But I think we can give it a reasonable try. All right. Perfect. All right. So we're going to try to use a little bit of different technique.
It's very fibrotic. So that's the challenge you feel in, especially in chronically occluded popliteal vessels. That's a big challenge you feel because these most of these segments are intramuscular through the Hunter's canal. So you will have a lot of fibrosis. Um, as as Dr. Kapoor was saying, there is a chance that you will have a lot of dissection planes. You have to accept the fact that what is your end goal therapy here? For him, that's what we have to see.
Right. I mean, the goal is to at least try to establish one inline flow down, relieve his symptoms, and maybe long-term wise, we can discuss the options of
Yeah.
goals of care, whether it be, I don't know, what we can talk. We'll talk about it later. I mean, there are multiple options, but in his case, we might be restricted because of his comorbidities right there. Ah, wow.
Wow.
Mm-hmm. My God. No. All right. I'm going to give you rail. See if you can go.
Yeah. Ray, push.
Oh, Karthik, you want to try? Go. Go forward.
No.
Wow. No. All right. Let's try to balloon there and see
Yeah,
if I can
we have to try to balloon
give it
there
a
and
shoulder.
see if
So try to see if you can balloon it. Try for get a little bit of
So
shoulder
whenever we
push.
have so much pushing and everything going on, it's a good thing to check the sheath, where the sheath is, so the sheath is not pushed up.
The sheet is in a
Just-
stand.
Okay, sheath is in right spot. Okay, good there.
Oh,
pull back. I'll pull back a little bit, and
Yeah.
then you can push in.
Go.
Yeah, go in.
Uh-huh.
Wow.
Wow. Ooh, wait. Wire comes back.
Maybe switch out 014 and then put a
Yeah, I
coronary.
think at this point I would switch off to an 014 and see
Yeah, we
if
might have to
that
switch our
helps.
wire back to 014 and use a smaller balloon.
A coronary balloon to see if we can get our track. This is a very good
So you
segment.
can see we're on the island in another orthogonal view, but we still have a lot more to go, but at least we're heading in the right direction. The biggest issue right now we're encountering is the passing of the microcatheter. So we have to really strategize on that part, and that's what Karthik is discussing about maybe downsizing it, which is probably just counterintuitive, but at the same time, we might have to get parallel. But at the same time, we just want to make sure we can deliver our things.
We'll start here. So I'm trying to work from above, and I think Dr. Kapoor is trying to get a pedal axis here in the peroneal. There are two ways of doing it. One is either we go ultrasound guided axis of the peroneal. If we cannot get ultrasound guided access to the peroneal, and sometimes the peroneal is difficult to access through the ultrasound, sometimes it's easy to do fluoroscopic guided, which is I think Dr. Kapoor, if I'm not wrong, is trying to do both fluoroscopically as well as ultrasound wise. He's going to locate it through the ultrasound and then probably go fluoroscopically and make sure that he's getting a
Here,
good stick
watch the
there.
sharp. Give me a long.
So even our coronary balloon, as we
Long,
see
long.
here,
7.
is having difficulty to track.
Yeah. No. All right. I'm gonna look down by the time. Yeah. So sometimes cases it look easy, but might have to do a little bit of fluoroscopy as well at the same time. So he's going to work from the top to see if he can find another channel. In the meantime, I try to see if he's going to balloon it, exchange for an oven 4, and I'm going to try to see we can go from here
Here you go.
and enter the vessel somehow where it's less calcified as well as a bit more coaxial to our system. So
Go more straight.
yeah, wow, degree of fibrosis is unbelievable in this case.
Yeah.
Okay, try one more time. Yeah, usually the coronary balloons are navigate a little bit more better because of their lower profile to cross. But in this case, probably it's not working in our favor. So I'll try to see if I can get a microcatheter down and loop from the top, because I think that's what the option is left right now, unless Karthik has something else to propose. All right, so we have a micro 7 centimeter micro needle down there. And the idea, of course, is to try to go at the V end, but sometimes because of spasm, we might have to migrate up.
Yeah.
So,
Nothing is getting down there.
all right, let me. No, I will. I just have to exchange it. Hold on. If you, all right, I'll let you do this, and then I'm gonna go over.
Flow in the peroneal is slowed down because of the spasm.
Yeah. But it's still dominant right there. He's right there. Here. And remember, we're also a little bit of occlusive on the top, and that might be giving us all the reasons. But you can see the peroneal. Yeah, I would probably go down, and you can actually see the spot right there where the dice is.
A lot of spasm.
Yeah.
The one is more deep.
Yeah, I know. That's what I'm trying to figure
So
out. It's
just
deeper,
get the.
deeper than.
So we can try another thing. We are going to try an 035. Walk this out.
Yeah, I think the best thing now to do is just go
035
035
dissection plane. Yeah.
and dissection plane and try to hopefully.
1 second.
Could I
Walk it out.
Sorry.
Leave him alone.
Huh?
Go. Wait a second. You shall leave it.
Yeah.
Leave it.
Yeah. I think just loop it.
Puff a little bit.
Yeah, puff.
Go down. Right.
Can you decrease the depth on the ultrasound? Perfect.
Go. Yeah.
I think you just have to. Good. No, the other way. The other way. Perfect. That's good. No, one less.
Okay. Feel it start here.
Perfect. Good. Yeah, right there. Right. So.
I think I crossed.
Huh?
I got it. So as you see, we changed it to an open 4 wire, and I think I was able to get through.
Let's take a
Let's try to
picture.
change it to a CXI catheter.
Hold on. Let's
Can
take
you
a
get
picture right
CXI,
there.
please?
I think it looks. Yeah. Got it.
So we created a bigger dissection plane, but at this point of time, I think we are
I'm
committed to
going to
it.
take a picture.
To we won't have a flow.
Yeah. Okay.
So,
So yeah, I think the biggest thing right now is it feels like intraluminal is straight. Now let's give it a shot. If it works.
It's a 014 wire in there.
All that. So I'm going to try to take a
so another way
picture.
to do
He's
it
right.
is the spasm of the peroneal is what will give us an issue.
Which is okay. I mean, we can give him medications and all till the time we know we are through to the vessel, and we're
Yeah,
right
we
in the
are in.
peroneal.
At this point, I think the only way to get through that fibrotic plaque, we tried
Was to get that plane.
we tried a foro balloon, we tried a coronary balloon, we were unable to get through. The only way was to create our own dissection plane. At this point of time, I felt like we are committed to having a stent placed here. That's why I made that call. But I would say we're going to IVUS again.
Thank you.
We
Right.
have.
So Karthik is right. We're going to IVUS again, but very important
Spartacore
learning
wire,
point
please.
is don't we like the loops, we like
Spartacore?
dissection planes, but what we call is control dissection planes. So we just want to make sure there is my peroneal. And after nitro, it looks nice and clean.
It looks nice and clean.
It's amazing how it was running away from us, and it still is, unfortunately.
So
But
Spartacore.
we see the two veins and the artery in the middle.
Right.
Actually, three. The third one is on the left.
The artery is also very diseased. So here is where we entered into the artery. You can see a dissection plane right there. So until 15, we look like we are based on the fluoro. That's where our entry point is. And then now this is all dissection plane.
Yep.
And keep going. I think this is the confianza which dissected our plane. I think
Which is
here
good.
we entered into a channel there.
A true channel, yeah.
A true channel there into the TP trunk.
And here you
Again,
can
this
see
is a dissection plane. And you can see the vessel on the side and everything. So we have a segment. That's what we have to see if we went into that. We went into that segment, but I think this is all dissection plane.
Which is fine.
So there are two options left for him. Either can consider a femtip bypass. So he's a resting pain patient with a low ABI and a propensity to technically based on the ABI, he's critical limb. So we can consider, think saying that I would probably not balloon that area.
I just have like one. You have to go.
Back.
Yeah.
I would say we bring back in a couple of weeks and then try it again, attempt it again. See, now our equipment is going in very easily and smoothly. And I think
I'll take
at this point, I would take a picture here because we have ballooned the segment. So just to see if you don't have any extravasation or anything, especially when you dissect a P1 segment. What's the final ACT? So we have a recoil in the P2 segment or P3 segment and the TP trunk area. And there is a thing. So what I would do is I would take a balloon again and balloon that segment from 10 to 15.